Hi, good morning or good afternoon, everyone. I'm Joe Joseph, and I will be walking you through cirrhosis today, one of the most important end stage organ diseases you will encounter, not just in exams, but also in clinical life. So, what makes so deadly the cirrhosis? Why is it irreversible? What's really going on inside that liver that transforms it all the way from a vital metabolic hub into a failing organ? So, today, let's go ahead and explore that. Okay, so here's our roadmap. By the end of this talk, we want to be able to describe what cirrhosis looks like both grossly and microscopically. We'll dig into the most common causes and complications, and most importantly, figure out how to differentiate from other liver pathologies, histologically and clinically. Think about this: how many diseases end in cirrhosis, but begin from totally different triggers or causes? There's a lot. So let's go ahead and explore that today. So, what actually is cirrhosis? It's the final irreversible stage of chronic liver damage. But what defines it structurally? We are now talking about diffuse fibrosis, the formation of fibrous septa, and regenerating nodules that completely distort the normal hepatic architecture. Now, functionally speaking, the liver starts to lose everything: synthetic function, detox abilities, blood flow regulation. This is where we see complications like portal hypertension, hepatic encephalopathies, the coagulopathies, and even hepatocellular carcinomas. So now the real question comes: can we catch it before we reach this stage? So here, I have a slide put together with a brief, concise introduction and definitions. So let's look at that. So what exactly do we mean by cirrhosis? Well, cirrhosis is the end stage of chronic liver disease. But what makes it end stage? It's that point where the liver damage becomes irreversible. But why does it become irreversible? It's because the liver's normal architecture is replaced by diffuse fibrosis, basically scar tissue and regenerated nodules. That form as the liver tries to heal or repeatedly heal itself. But here's the problem: these nodules are disorganized. So instead of helping, they actually disrupt, obstruct the normal blood flow and function. Now, once this architecture is distorted, it's messed up. The liver starts failing functionally, and we start seeing major complications. For instance, or as you see in the slide, we have portal hypertension, which leads to varices, ascites, and splenomegaly, hepatic encephalopathy. Patients become confused, even they go into coma. And we have seen and heard about asterisks before, right? So that's the connection we have over here. Coagulopathy, because the liver can't produce clotting factors, it's lost its synthetic function. Hypoalbuminemia, which contributes to edema and ascites. And then there's jaundice, cholestasis, and even hepatorenal syndrome or hepatocellular carcinoma. So the next big question is, what causes this cascade of damage to begin with? Most often it's chronic alcohol use, viral hep B or C, non-alcoholic fatty liver disease, or autoimmune hepatitis. So cirrhosis isn't just a pathological endpoint, it's a clinical launchpad for systemic dysfunctions and diseases. Again, so just to have it all here together, what causes this downward spiral? Yes, it's alcohol is the major culprit, but so are chronic hep B and C, and the non-alcoholic fatty liver disease and the autoimmune hepatitis. Then we have the biliary diseases like the primary biliary cholangitis and the primary sclerosing cholangitis. They also play a big role. And here's a deeper question, though: can fibrosis ever be reversed if we catch these causes early, or is cirrhosis a one-way street? That's what we need to keep in mind clinically to help our patients. So let's look at the liver itself. What would you expect to see with your eyes or on imaging? Would you be able to notice the nodular surface, those regenerating hepatocytes surrounded by bands of fibrous scar tissue? And the contour is obviously irregular and it's shrunken. And in imaging like MRI, these things can become quite apparent. And we'll look at those in the subsequent slides. But here's a puzzle: how do you distinguish a regenerative nodule from a malignant one, like the hepatocellular carcinoma? This is why imaging needs to be paired with clinical suspicion, and that's an important thing to keep in mind. Moving on, now let's take a look at the liver from the outside. What do you see and notice immediately? This isn't the smooth, soft organ we expected. This liver is nodular, distorted, and firm. And those nodules, they're larger than 3 mm, which classifies this as macronodular cirrhosis. But why do these nodules form in the first place? Well, it's the liver trying to regenerate after chronic injury, whether from alcohol, hepatitis, or another cause. But the regeneration is happening in the context of ongoing fibrosis and scarring. So the architecture becomes distorted, chaotic. You can also ask yourself, what's that arrow pointing at? That's a clear regenerative nodule surrounded by fibrotic bands. The firm texture comes from dense collagen laid down during the healing, which ironically ends up impairing function. So here's a big question again. If structure determines function, how well do you think this liver is still going to be working? Probably not very well, right? And that's the central tragedy of cirrhosis. The organ is trying to heal, but the healing process itself becomes pathological. So now here's a different pattern. This is micronodular cirrhosis. What's a key difference compared to the macronodular liver we just saw earlier? Take a closer look at the surface. These nodules are much smaller, less than 3 mm. They give the liver a more uniformly bumpy or finely nodular texture. So what causes this pattern? Classically, chronic alcohol use is the most common etiology. The liver cycles of injury and regeneration over many years and the repeated insults create these tiny regenerative nodules encased in fibrotic tissue. But here's something to think about. Can macronodular and micronodular patterns evolve into one another? Yes, they can, especially as the disease progresses or if the multiple insults are present. So this isn't just about classifying gross patterns. This tells us something about the timeline and likely etiology of the patient's disease. All right, we have a cirrhotic liver in the MRI over here. Now let's look at what this cirrhosis actually looks like inside the body using imaging. This is a transverse MRI scan of the abdomen. Do you notice how the liver pointed out by the arrow appears shrunken and nodular? That irregular contour is a classic radiographic clue pointing to cirrhosis. It's not smooth or uniform. It's distorted by those regenerative nodules and fibrous tissue we just talked about. But also, take a look at that large white structure on the left. And can anybody tell me what is that? That's the spleen, and it is enlarged. Why? Because of portal hypertension. As the fibrotic liver impedes blood flow, the pressure builds up in the portal system, backing up into the spleen and causing congestive splenomegaly. So here's a clinical question we have to keep in mind. If this MRI was shown to you in a vignette, could you correlate these findings with things like thrombocytopenia or esophageal varices? That's why imaging just isn't confirmatory. It's part of the diagnostic puzzle in cirrhosis. So here now we're going to zoom in and look at what cirrhosis looks like under the microscope. But just before we move on looking at the images, let's keep in mind, this is going to be a H&E stain section of the cirrhotic liver, and it has a few hallmark features that we should always look for. Things like bridging fibrosis, bands of fibrous tissue that connect portal tracts to one another or to the central veins. Why is that important? Because it disrupts normal blood flow and lobular architecture. Next, look for those regenerating hepatocyte nodules. These are clusters of liver cells trying to regrow within the fibrous network. But without the proper organization, this regeneration is dysfunctional. And then you will expect to see mixed inflammatory infiltrates, primarily in the portal areas. These are things that mean there's chronic immune activity still going on, contributing to further damage and fibrogenesis. The thing to keep in mind here is if you see slides like what you're just about going to see on a test or in the path lab, could you explain how each of these features links back to the impaired liver function? And that's the best part about this histology, clinically relevant. Not just making pattern recognition, but you're able to connect a mechanistic understanding where you can make a connection and association to the etiology. So here we are. Cirrhosis isn't always straightforward. What other diseases can look like it histologically or clinically? Things like hemochromatosis with iron overload, bronze diabetes, or Wilson's disease, especially in young patients. And then there's alpha-1 antitrypsin deficiency that shows fast positive globules, and also drug-induced liver injury, biliary atresia, cardiac cirrhosis. Each of it has its own trigger, clinical clues, and histologic footprint. So here's a real challenge. How do we tailor the workup to differentiate them? So looking at this image, you'll see those fibrous connective tissue, and you'll see the regenerative nodules. And within these collagenous tissue, the fibrous tissue that's scattered, you'll see lymphocytes as well as proliferation of bile ducts. Again, there's another microscopic image. So let's zoom into this histological level. What are the key features? You'll see bridging fibrosis, bands linking portal areas, regenerative hepatocyte nodules, and it's trapped in the fibrotic cages, and often a mixed inflammatory infiltrate, especially in the portal tracts. Here's the thing you should ask yourself. If you had this slide on your exam, could you recognize cirrhosis immediately? Could you explain what the presence of inflammation means for this ongoing change? Now, I just put together a quick differential diagnosis table in the next two slides that you're going to just see. Cirrhosis is the final common pathway of many liver diseases, as we all know, but each has its different backstory. So let's quickly walk through some of these highly differentials. We have hemochromatosis. You're going to see thinking iron overload, like bronze skin, diabetes, heart problems. We got to confirm it with iron studies and the gene HFE testing, Wilson's disease, that's the copper deposition overloads. And then we have issues related to alpha-1 antitrypsin deficiency. And we need to look for liver disease in young people. And, you're going to see some emphysemas as well over there. And then, there's fast positive globules. Those are some certain key identifiers, we'll be able to quickly match up and identify. And then we have the cardiac cirrhosis. Cardiac cirrhosis caused by the right heart failure. We need to look for nutmeg liver and signs of systemic venous congestion. So then we move on to the next slide. And this is the continuation of this, the previous differential diagnosis table that I had shown. And the question over here is, why is cirrhosis so high yield for step one? The reason is because it connects multiple pathophysiological systems. You need to understand how portal hypertension leads to varices, why platelets drop due to splenic sequestration, and how synthetic function is important. because if there's synthetic dysfunction, then there's low albumin or elevated INR. Sorry. And it's also key to understanding the mechanisms of the complications, like how ascites develops or why patients become encephalopathic. Okay. So I will move on to the next slide. So when it comes to step one, like cirrhosis shows up all over the place. Every Q bank has it, practically speaking. So what should you focus on? First, be ready for classic complications like variceal bleeding, the hepatic encephalopathy, or even hepatorenal syndrome in a clinical median. Next, understand the mechanism of portal hypertension. It's not just elevated pressure, it's due to increased resistance to the fibrotic liver, which causes the backflow to the spleen and GI tract. And then we have the synthetic dysfunction. This is a big key. Low albumin leads to edema and ascites, while prolonged PT-INR reflects impaired clotting factor production. And finally, lab patterns are important because when you think elevated AST, ALT, increased bilirubin, low platelets, not from marrow failure, but due to splenic sequestration from portal hypertension. So ask yourself this question: can I connect these findings to the underlying pathophysiology of cirrhosis? That's the kind of integration step one is testing. So why does this matter for step one and for the wards? Think of cirrhosis as a blueprint, like a roadmap for many high questions. And here's a perfect step one style case I have for you. We have a 56-year-old man, a classic history. I'm going to pause and let you take a minute to read. All right, so let's break it down now over here. So what we just saw is a real step one style case. This case shows a man basically with alcoholic liver cirrhosis, now presenting with confusion and abdominal distension. His labs show hyponatremia. And so what's going on? And what's the thing that's driving us to the right answer? And that's hyponatremia. So let's break it down. It's not true that sodium loss, A, is the answer, and it's not from osmotic diuresis or urea. So we eliminate E right away. And then while GFR may be reduced, that's not a key driver in this mechanism, but the correct mechanism is B. That is a dilutional hyponatremia due to increased ADH secretion. Why? Because in cirrhosis, portal hypertension leads to splanchnic vasodilation, reducing effective circulating volume. The body interprets this as hypovolemia and triggers non-osmotic release of ADH. ADH then causes water retention, diluting serum sodium. So always ask, is the low sodium due to water excess or sodium loss? In cirrhosis, it's almost always water excess. Dilutional hyponatremia. So all of this information comes from our core resources like Robbins, Pathoma, WebPath, and these aren't just like reference books, like they are essential for building your clinical reasoning. So in closing, what's the main takeaway? Cirrhosis is not just liver disease, it's the endpoint of 1,000 pathways, and it gives rise to complications that span the entire body. If we can understand it structurally, functionally, and pathophysiologically, we'll not only ace our exams, but also actually catch it before it's too late in our real patients. Thank you for your attention. I would love to hear your questions now. This a final slide that brings us to the end of this presentation. I hope today you're walking away not just with facts about cirrhosis, but with questions that will guide you deeper. And your understanding of cirrhosis has improved greatly. Why does this liver fail the way it does? Why or how can we spot the early signs of cirrhosis? And most importantly, can we intervene before it's too late? Thank you for your attention. Let's open it up for questions. And if there are no questions, I wish you all good luck. Thank you.